Brought to you by Dr. Joe Ordia. Frequently asked questions about neurosurgery and pain management. Questions 71 to 75. Herniated disc, diagnosis and treatment. I start with a disclaimer. The opinions expressed here are for general information and based on my own professional experience. They are not intended to replace the advice of your healthcare provider on your particular condition.
Question number 71. In our previous session you described some of the causes. What can I do to reduce my risk of developing a herniated disc?
Answer. Your commitment to preventive care is commendable, as it is often a better approach than focusing solely on treatment. Preventive strategies include regular exercises and stretching. Eating a balanced diet and keeping a healthy weight can alleviate stresses on the spine, while avoiding smoking enhances blood flow and nourishment to the vertebrae and discs. Practice good posture, use supportive shoes, and follow correct lifting practices. Choosing a firm mattress supports spinal alignment and promotes restful sleep.
Question number 72. A friend of mine recently arrived in the U.S. as an exchange school teacher from Europe. She developed problems with sciatica and she did PT for 4 weeks, but the pain did not improve. Her primary care physician referred her to a spine specialist, and she was surprised to be asked nearly the same questions she had already answered for her PCP. She wanted me to ask you why the specialist did not copy the information from the computer to their record to save time.
Answer. Having a discussion with her specialist serves to establish a professional patient-provider relationship and opens up a channel of communication where she also has the opportunity to ask questions. The standard of care calls for the specialist to obtain an independent history rather than relying on notes that could contain some error. In addition, based on the answers to targeted questions, the specialist can more effectively zero in on detecting any specific nerve roots that could be involved and to look for potential causes outside the vertebrae. Medical knowledge is constantly evolving with new discoveries that enhance diagnostic tools and surgical techniques. Evidence-based guidelines are frequently updated as clinical data emerge. The specialist is more likely to be familiar with new breakthroughs related to her condition. Applying this knowledge effectively requires a deep understanding of her unique circumstances and making individualized decisions.
I certainly get it, and I will convey your response to her. Merci beaucoup, docteur. Question number 73. Can you explain how a herniated disc is diagnosed?
Answer. Making a diagnosis often begins with a detailed medical history which can provide insight into the present symptoms and form a basis for understanding previous and present illnesses, treatments, medications, and other health-related issues. Some patients have mentioned to me that they were embarrassed to discuss certain symptoms when speaking with a provider of the opposite gender. A medical condition reflects neither personal failing nor fault. It calls for empathy and compassionate care, not judgment. There is no reason to feel embarrassed. Withholding important information can hinder the ability to receive optimal care. The history is followed by a physical examination, which primarily focuses on the musculoskeletal and nervous systems, but the cardiorespiratory and other systems are evaluated as well. Even when the history and physical examination point to a herniated disc, an imaging test may not be ordered at the outset, given that herniated discs often shrink over time, with 85% to 90% resolving within 6 to 12 weeks. However, uncontrollable pain or the presence of any red flag symptom, such as loss of bladder or bowel control, loss of sensation around the rectum and buttocks, foot drop, infection, cancer, or acute fracture, may require blood tests and prompt imaging. X-rays are excellent for visualizing bones, but not soft tissues like acute herniated discs, which are better seen on MRI. CT scan may be used if the patient has an implanted device that is not MRI compatible or conditional, or that may create an artifact. Patients who have failed to respond to physical therapy, a home exercise program, or appropriate pain medications may also be candidates for MRI or CT to assist in guiding further treatment. If questions remain about which nerves may be contributing to the symptoms, electromyography, EMG, and nerve conduction studies, NCS, may provide information about the electrophysiological activity of the nerves.
Question number 74. What are the treatments for a herniated disc?
Answer. I explained earlier that herniated discs frequently shrink over time, with 85% to 90% resolving within 6 to 12 weeks. In the absence of any red flag symptoms, this time frame is a good opportunity to focus on conservative management. Measures include a home exercise program, physical therapy, pain medications, which may include non-steroidal anti-inflammatory medication, oral steroid, and gabapentin, which is used to treat neuropathic or nerve pain. Referral may also be made for acupuncture or chiropractic treatment. If there is no sustained response or the symptoms worsen after 6 weeks of conservative management, MRI or CT scan may be obtained to confirm the diagnosis. Identifying a herniated disc with nerve compression can open up additional treatment options. Epidural steroid injection delivers a small amount of an anti-inflammatory steroid directly on the nerve using image guidance, aiming to reduce inflammation caused by mechanical compression and inflammatory chemicals that are released by the disc. Surgery is considered if reasonable conservative treatments prove to be ineffective. In the lumbar spine, the primary objective is to remove the herniated portion of the disc to alleviate compression on the affected nerve. There are different approaches to the disc. Some are minimally invasive, while others are open. To reduce the risk of reherniation, some surgeons use an annular closure device to close the opening in the outer ring through which the disc herniated. When recurrent herniation occurs at a site of a previous discectomy, repeat discectomy, along with lumbar interbody fusion, is considered to reduce the risk of yet another herniation in the affected area. For certain spinal conditions, an anterior approach through the abdomen to the spine can be the preferred method. A vascular surgeon may be needed to safely navigate through the blood vessels and provide surgical exposure for the spine surgeon. The surgeon will explain the type of surgery that is best for your particular condition, the potential risks, and realistic expectations. While the leg pain and abnormal sensations may gradually improve, removal of the disc does not directly target relief of back pain. The key here is to maintain stretching, exercises, ergonomics, and the other preventive measures that we talked about.
Question number 75. So, what types of surgery are performed for a cervical herniated disc?
Answer. The surgical approach to a cervical herniated disc is largely determined by the type, size, and location of the herniation relative to the spinal cord. In adults, the spinal cord typically ends at the level between the first, L1, and second, L2, lumbar vertebrae. Unlike the nerve roots in the lumbar area, which can withstand gentle retraction to reach the disc, retraction of the spinal cord carries risks including reduced blood flow, called ischemia, swelling, also known as edema, and potential paralysis. If a disc extrusion or sequestered fragment is located at the side of the spinal cord and compressing the nerve root, a posterior surgical approach may allow for targeted removal of only the herniated section. On the other hand, if the disc is compressing the spinal cord anteriorly, it is often safer to approach it surgically from the front of the neck. The entire disc is removed, and the surgeon can choose to either perform a fusion or proceed with cervical disc replacement, CDR, using a device that allows for some motion at the joint. Anterior cervical discectomy and fusion, ACDF, of two vertebrae causes more motion and increased stress at the adjacent discs and joints. A few years later, some patients develop degenerative disc disease and arthritis in the joints, a condition known as adjacent segment disease, ASD. The changes can result in nerve root or spinal cord compression and require further surgery. To be eligible for cervical disc replacement, CDR, the conditions that have to be met include healthy, mature bones, absence of severe arthritis, osteoporosis, or other metabolic bone disease. Your surgeon can discuss the recommended option for your particular condition and the potential risks.